Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. Please make use of it and also please give your comments. My dear friends, as we know, we have been discussing about differences in sexual differentiations in so many classes. In the last class, we have seen uh, why there will be formation of ambiguous genitalia and what you have to suspect whenever there is ambiguous genitalia. So now today we will see an approach towards a case of ambiguous genitalia. Suppose when you get a baby, you find a baby in the delivery table. After receiving the baby is the sex is it's very difficult to determine the sex because it is ambiguous. Now what should be your approach? First of all, you have to ask the family history. There are so many chromosomal disorders, so where you can find this ambiguous genitalia like conditions, especially autosomal recessive type. Okay, this is the first step. Autosomal recessive type of inheritance disorders, we will have multiple disorders are there where we can find ambiguous genitalia. Number one, details we will see later. Number two, you should ask about the history of consanguinity. Consanguineous marriage, most commonly the consanguineous marriages leads to the increased incidence of autosomal recessive, not autosomal and X-linked recessive type of disorders. Third one is you have to ask the history of infertility in the maternal aunts, maybe maternal uncles, or that is from the maternal side, maternal uncle, maternal aunt. So whether there is any history of infertility from that side, especially maternal aunt and maternal uncle, so that is also very important. You should also ask the history of sibling death. Okay, sibling death, whether there is a sibling death, previous history is there, history of sibling death in this particular couple or maybe in other couples in the family, so that you need to ask. One of the most common is salt wasting type of this adrenal problem, so that usually leads to the early sibling death. Then the last one, you have to ask the DSD in the other siblings. In the other siblings also there is some problem like ambiguous genitalia. Is it, if it is present, you should record it. So these are some of the basic things that you have to ask in the history. So whenever you find a case of ambiguous genitalia at the time of the birth. Now come to the next part, that is history in the pregnancy. In the pregnancy also you need to ask some of the history points. Number one is whether during the pregnancy any androgenic exposure, very important. In the last class we are discussing about the critical window period, the amount of the hormones, duration of the presence of these hormones, quantity, etc. So this is very important. In the critical window period, if something went wrong, definitely child is having a formation of the deformed or abnormal external and internal genital organs. So therefore androgen exposure, especially for the female, is very important. Androgen exposure of the maternal time, that is mother to the mother, so that is very important, because a time where there should not be any testosterone. Unfortunately, if the testosterone by some method, some causes, if the testosterone is increasing there, or if the androgen which has to be there, so if its amount is more than the requirement, so all these factors contribute for the formation of the ambiguous genitalia. So that is one point, that is any androgenic exposure. Number two, does any virilization in the mother, maybe virilization, mother undergone some virilization, okay, like maybe aromatase deficiency in the mother, in the placenta, maybe result in the virilization of not only the fetus but also the pregnant mother. Okay, so point is any aromatase deficiency in the placenta may also result virilization of the fetus and also the mother. So history of virilization during the pregnancy time is also very important. As the child grows, the child may have lack of breast development. Okay, history in the pregnancy. Now as the child grows, the child may have the lack of breast development, which is commonly seen in P450 deficiency and also luteoma. So this also we will discuss in the later part. Now coming to the examination part, if you see after the birth, you need to see the gonads. What is the size of the gonad? If it is very small, okay, tiny, sometime abnormally big, maybe, or sometime very smooth, very small, round, just nothing can be appreciable, just a round subject like a round thing is palpable. Okay, so possibly it is a testis. Possibly it is a testis. Now you have to look into the size of the testis. Okay, is it clearly palpable? Is very small, tiny, or just a some appreciation is there, just like round thing is there, but you cannot even say is it a testis or not. So such thing has to be examined at the time of the birth. Sometimes even the ovary may be also palpable as a globular structure. Of course, it is very rare in the female child. Even sometimes the ovary may be also palpable as a globular structure. Now then look into the genital openings. This, as I already explained, examination of the genital opening is very important. We know the slit, vaginal opening here, and the urethral opening, penile urethral opening in case of male, and the vaginal opening in case of female. So its length and also the diameter, that is also very important. Now if the Mullerian duct proliferation is normal, okay, so then this genital opening etc will be absolutely fine. But if it is abnormal, then there may be some Mullerian duct proliferation problem, and this can be get confirmed by USG also. Okay, that means by after doing the USG, it is not only the external genitalia, and you can also look into the internal genital structures. Okay, if there is no formation of the internal genital organs like the fallopian tubes, uterus, and other internal genital organs, so then it clearly suggests that there is formation with the Mullerian duct proliferation. Okay, abnormal Mullerian duct proliferation syndrome. Now, if there is only one opening, that is, suppose if there is only opening is there, sometimes we see the urethral opening, and sometimes we see the anal opening, but there is no vaginal opening. The baby has given to the parents telling that this is a male. So what to do now? Now this is a real practical problem that we face. So baby's delivery has been taken place now, and there is only one opening is seen in the vestibular part. Okay, there is one opening is there, and on the back side posteriorly we will have one anal opening is there. Okay, anal opening is there. Now the problem is, if it is only one opening, that is in case of males, that is urethral opening will be there. Urethral opening, isn't it? Penile urethral opening. But if you want to say that this is a female, there should be two openings. One is urethral and also vaginal opening in the vestibular part. Okay, so when you are handing over the when you hand over the baby to the parents, now you will be in a confusion what to say, is it a male or is it a female, isn't it? So that time you have to tell the truth. Actually, we are not able to differentiate the sex properly. It may need some time, or it may even need some investigations. Okay, so now because the phallic size, if it is less than 2.5 centimeter, then we will call it as micropenis, and if it is more than 1 centimeter, it is called as clitoromegaly. Okay, clitoromegaly. Now this is a problem. Clitorius, that means if the length of that particular structure, phallic length, if it is more than 2.5 centimeter, we will call it as, yes, it is a penis. But if it is less than 2.5 centimeter, yes, it is called as micropenis. Okay, and if the phallic length is more than 1 centimeter, then it is called as clitoromegaly. It may be clitorius. So presence of the clitoris, it may be a female. It may be female with the clitoromegaly. I hope you got the point. But is it a penis? Really, it is a normal penis. We are not able to explain at that point of the time. So therefore, clitoromegaly is there. Now you have to decide whether it is a penis, really penis, whether it is a micropenis, or whether it is a clitoromegaly. So this is very, very a difficult part. Okay. So then the stage of virilization, there are so many other factors are also there. That is internal and external masculization score is there. According to that score, you have to now calculate. Some other grading systems are there, like Quigley grading system for XY DSD, for the males, and similarly Pradar stage of virilization for the XX DST for the female. So you have to take help of all this grading system also to confirm the sex of the child. Now another thing is anogenital ratio is also used. If it is more than 0.5, it suggests the virilization. Similarly, clinically, if there is hypertension is present in the child, then 17 alpha, 11 alpha, 17, 20, that is 17 alpha deficiency, enzyme deficiency. So such things are also common. That also we will discuss in the next class also. So if there is hypertension, okay, 17 alpha deficiency, 11 alpha deficiency. Similarly, if there is hypertension, most common the problem is salt wasting type of congenital adrenal hyperplasia. Salt, that is adrenal deficiency, not adrenal hyperplasia, adrenal deficiency, salt wasting type. Okay, so if there is hyperpigmentation, suppose hypersegmentation, then it is indicative of early steroidogenic pathway defects. Okay, then if there is any other associated anomalies are there, like skeletal anomalies are there, then there may be SOX defects. Okay, syndactyly is there, then it is suggestive of Smith-Lenti optic syndrome. Okay, if some renal problems are there, and there may be some palmoplantar keratosis. Okay, there are R spondin 1 defects. So these are the different aspects which we will go into. I am not covering here because only for the examination purpose I am telling this. Examination of the child. Okay. So we have to look into the renal problems. We have to look into the plantar keratosis. We have to look into the associated anomalies like skeletal problems, etc. Okay, facial. There is face that is stereogenic. Sometimes steroid-like face will be there because of the adverse effects of the steroids. So these are the points that you have to observe during the time of examination. Okay, what are the investigations that usually we will suggest in such cases of ambiguous genitalia? Serum electrolytes, because it's very important, because adrenal gland will produce 3 important hormones: mineralocorticoid, androgens, and cortisols, isn't it? So mineralocortical deficiency definitely leads to the serum electrolyte problems also. So karyotyping has to be done, fish analysis for SRY. Similarly, 17 OHP on the day 3 if it is less than 15 nanomoles per liter. Then we have to go for testosterone assay, must and should. 21 alpha OH deficiency, we have to go for investigation for that. If there's a classical type, non-classical type, typical, atypical, like that we will see in detail. Then rule out the stress, prematurity, and also intake of antenatal steroids. So this is what I'm telling, the critical window period. If the steroid quantity is more, mother is supposed taking some of the steroid preparation for some other problems, or mother's body is producing some extra steroids due to some problems. So that will be all lethal cases. Okay. Now radiologically, what are the investigation you have to do? USG. USG helps to find out the formation of the internal genital organs, whether it is formed normally or not. So that means Mullerian duct problems. Okay. It also helps to identify some of the renal problems and genitograms. Now second level lab investigation that includes DHT, dihydrotestosterone, and 11-deoxy cortisol, anti-Mullerian hormones, SCG stimulation test, and ACTH stimulation test. Okay, so this is in a short approach towards a child with the ambiguous genitalia. So in the next class, we will have a detailed approach towards the DST. This is in short I am telling. Okay, thank you very much. In the next class we will meet again. Thank you very much.